Hi guys, Liam here from Whiteley Oil Care. I'm just with Maggie Oles today and we're just going through some dynamometers and how she uses it. So we're going to do a slight quick Q&A here to start, just questions that we've been asked and maybe Maggie has been asked also. So just to start off, Maggie, I suppose you would have been using, you've been using dynamometers for the last two and a half years now.
Yeah.
What would you have been using previously to that, before dynamometers?
Prior to that, I was just doing, that's me doing external rotation, just some manual muscle testing, trying to detect differences one side from the other. I really have enjoyed using this. I think patients like being able to see the numbers and getting that feedback. It also gives me a more exact reference, and this dynamometer will measure your peak force or peak torque, so it's quite useful finding those max outputs. So it gives you a bit more of an exact indication of where the strength deficits are.
Great.
And
in terms of reliability of the device, how do you find that?
So I think what's important for people is they always put the patient in the same position. They always are putting then the dynamometer in the same position. We know for the shoulder, for example, it's more reliable if people are lying down versus sitting, versus standing. People brace in different ways. It's really important that people measure the patient in the same way. They put the dynamometer in the same position, and then they are consistent with the advice that they give them.
Great. I get asked a lot of questions in terms of using a solid surface. So, for example, if we're talking shoulders, using a wall as for external rotation versus using the practitioner as the breaking point. What are your thoughts on that?
What's really important is that it's a measure of the patient's strength. Do you know, like if I'm not strong enough to hold that in an isometric position, then it measures my strength versus the patient's strength.
Yes.
So if you can't position yourself in a way that the dynamometer doesn't move, you're better to use something stationary. Some of that is around patient positioning, but also some therapists are quite little, and so I can hold my force here, but if you're smaller or you've hurt your wrist or whatever, then what is important is that the dynamometer doesn't move, and it's a measure of the patient's strength, not the therapist's ability to hold it.
I think you said a key point there was in terms of bracing yourself as a practitioner. I see a lot of clinicians when they're testing, they don't get themselves in the right position.
Yeah, right.
So I think you're spot on there with bracing and getting yourself in front of the thing. So
for me, I always lock it into because then all I'm doing is holding it with my body rather than being out here. There's no way I can resist some people in that position.
Yes.
So just thinking about the position that clinicians put themselves in, so that they don't hurt themselves either. I think that's important.
Great. Moving on slightly, in terms of pain, so if your patient is in pain, is there anything you recommend, or what do you use as protocols there?
So what you need to be careful of, I guess, in the first instance, that using the dynamometer doesn't exacerbate their symptoms. We need to be doing this as a measure of pain. There's a few questions around the reliability of that, and that pain is so multifactorial. It's not just dependent on load. So having a clinical awareness or thinking about all those other factors that could be causing pain. I think clinically what I do is get patients to slowly build up as a ramp so that they can feel when that pain is going to come on, and they stop at that pain onset, what we would call P1. So and then the clinician would take that as a measure.
Okay.
There hasn't been much research in terms of documenting that over time, and also documenting the reliability of dynamometry in painful patients. A lot of the reliability work has been done in healthy normals.
Yeah.
So it's just a note of caution to clinicians to be careful when they do that.
I suppose, as you say, you don't want to put the patient in.
No, you don't want them having more pain after you've done your testing.
100%. You're trying to get a peak force value or an average value so you can retest. But
yeah, you don't want them to be worse off after your session.
Hi guys, so we're just going to do some shoulder testing here. I suppose how Maggie has tested and how she tests her patients.
Great, so you lie down. One of the favourite places I do that in is at 90 degrees of abduction, and so here in neutral, what I would test then your external rotation strength. So I position myself so that my hand is on the back of your wrist. So I'm in that position, and my instruction to the patient is it's over 5 seconds. I want you to then push as hard as you can. Just ramp up to your max force there. So when you're ready, 3, 2, 1, go. Push hard, push hard, push hard. Great. And that gives us a score of around 15 kgs. I think I like showing the patient. I see him, I've showed them, not showed them, that patients really like the numbers and they like the biofeedback. I think what's important then is you give the patient a rest before you retest them. I think what we're advising is 3 tests, an average of that. Sometimes you get a bit pushed for time in the clinic, but that's generally standard practice. So I would measure external rotation in this side. Sometimes I then scoot the patient just across the bed that way and then put them in this position. Same thing, I just swap hands, hold here, ready, 3, 2, 1, go. Push hard, push hard. And then I document those numbers. I think one of your new fancy ones can export things, can't it?
Yes, yeah.
I just write those numbers down. This is the one I have in the clinic that I'm working with at the minute. If you scoot back to that side of the bed and then position people so that their arm is supported, then I would get them, I don't know if you can see, in that position, and that would, ready, 3, 2, 1, go. Push hard, twist down. You need to twist down to the floor, twist down. I think what we need to be aware of here when you're measuring internal rotation, it's not adduction, it's internal rotation. I made that mistake before because some people are really strong and will pull you that way, and so you really get a measure of their adduction strength rather than their internal rotation strength. So my instruction to them is twist your hand to the floor, because I think that gives you a better indication of their internal rotation strength. You can always do this then in sitting and measure their abduction as well. Sometimes I also measure them in external rotation here. Again, the key is be consistent. If you're going to measure them there, then that's where you need to retest them. You need to document that in your notes so that when you go back a few weeks later, where did I test them? You've written that down and you know.
I think one of the key points you said there was about consistency.
Yeah.
So one question I might ask for you would be, if we are doing shoulder or we're doing knees, I think where the patient puts their other hand, or I think that should be almost
right. And I think
by holding onto the table you could obviously get.
And I think that you get a bit more limited, like when you're lying supine doing that, because you can't stabilize yourself anymore. Definitely, I know if you're sitting up, if you just sit up here, if you say we are measuring your adduction strength, which I would measure here in that position, again I would position this just proximal to the elbow, and I would then push here so that you push out, and we're measuring that. That's going to be different if you stabilize there versus arm across your chest.
Yes.
My preference is for the patient not to be stabilized, and that's what you're measuring. Otherwise I'm measuring probably your adduction strength on the other side.
Great.
Okay?
Great.
Okay, so you can also then measure abduction in around 45 degrees. I'm going to put my hand there, just proximal to his elbow on his distal humerus, and then get him to push out as hard as he can. So when I say go, 3, 2, 1, go, push hard, and relax. What you need to be aware of then, that he's not bracing on that side, that inside would have put his arm up here on the chest. Do you want to do that again? So in that position, your arm is on here, ready, 3, 2, 1, go, push hard, push, and relax. So that's 5 seconds with that ramp. So, okay.
Hi guys, we're here again. We're going to do some knee testing. So previously with the shoulder we would have used the Activforce original, and this is a new device, Activforce 2, that has just came to our doorstep about 2 weeks ago. Main difference between Activforce original and Activforce 2, you have a range of motion built into this device, and it also picks up peak force versus average force. And lastly, which is quite nice, you can send the data you do on the app directly to your email. Whereas previously, before, you might have been jotting down the notes manually. So we're going to quickly go through the knee testing here with Maggie.
So I think what's important here is that you are in around 80 degrees of knee flexion, and that you're, again, consistent with your positioning. The cool thing about this one, it has that little soft cover, doesn't it, for your shin?
It does. Yeah, so I'll quickly show you guys. So there's a little bit of difference here. It has, patients were complaining before that it was quite firm on the shins. So Activforce have designed this little click-in mechanism which makes it softer for people. So they're not complaining about pain on the shin. We've simply just attached this to the treatment table using the new Activforce 2 comes with a seatbelt design where the Activforce 2 can sit into the actual seatbelt. If you're using the Activforce original, you can easily, I'm sure you have a seatbelt in your clinic and you can do it that way.
So I think what we had done, like for the Kiwi pathway, was around testing the uninvolved limb before you test the involved limb, using a warm-up trial of 50, 75%, 100 MVC,
okay.
and then 3 trials of max, and then average your max.
Okay.
So there are some, again, it's just consistency, that this is always placed in the same place, and if you're going to brace here, then you would brace consistently. You know, like I think we talked about that before, whether you are behind or in front bracing, just be consistent.
Yeah, I think one thing we made a point on was, if you lean back, for example, here, you're testing a lot more muscles rather than if you're staying upright and grabbing maybe towards the front of the treatment table, or else crossing your arms in front of your chest. I think you're using the muscles that you want to test.
And the key thing is be consistent. Yeah. However you do that, just be consistent with it. It was also then the calibration, but I think we're going to. So when you first then don't press or move, then, so I'm just gonna hold that in place there. I'm just sort of holding it on his shin so it doesn't fall off the side. So I'm just gonna hold that in place there on the shin so it doesn't slip off around the side. You're gonna press on the right side, put the patient's name in there, and then wait for it to calibrate. It's a bit different than using the other one, isn't it? So push hard, push, 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 push hard, push hard, push hard, go, 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 push hard, push hard, push hard. Brilliant. So that would be a test then over 5 seconds. You can then give them 30 seconds rest at least before you would test again. Do that 3 times and then get your average.